effect with these agents. So how does this happen? And when you see a slide like this, I think you can appreciate we don't know the answer. I think it's certainly clear that there's a diuretic effect and a natriuretic effect of these agents, which is well understood from the renal effects, and that may translate into cardiac changes. Interestingly, when you have this sort of loss of fluid and sodium, you'd expect a raise in heart rate, and we know we don't get that. And so that absence in tachycardia or absence in change in heart rate is unusual, and we do think there's even a sympathetic renal effect of these agents. There's also a suggestion there's a metabolic effect. So these agents are slightly ketotic, or they produce ketones, and that may be beneficial for the heart. But I must say it's really not well known. Even uric acid changes that may be beneficial. So it's still up for grabs, and we really don't understand. This is one of our publications. So we looked at patients who had been commenced on empagliflozin, and this was a cardiac MR study. And if you look at the top line of the study, the only significant difference over 6 months we found in cardiovascular numbers was this end diastolic volume, which was reduced significantly compared with the control group by 15 mils. And the rest of it, ejection fraction, left ventricular mass, resting heart rate, etc., they were all unchanged. So that's a hint, if you like, but there are certainly many other mechanistic studies, particularly using cardiac MR and echoes, underway. And once again, we're not certain what the exact mechanism is. So let's talk about incretins finally, because we know that there's this enteroinsular axis. So there's a communication between the gut and the pancreas or islet cells here. We've known that for a long time, and the main communication is via GLP-1 and possibly GIP. And the pharmaceutical industry has been all over this, and certainly GLP-1 agonists are effective therapies now. They're injectable agents. They're associated with increase in insulin production, reduced glucagon, reduced gastric emptying, and appetite suppression. And so we see nice weight loss and improved glycemic control with these, and they're important glucose-lowering agents and obesity agents. So there's a range of these, and you can see that they vary in structure, but if you look in particular at the half-life, we go from short-acting to long-acting here, and we can see that there's differences in structure and spaces, etc., that cause these differences. But it all began with exenatide. So this was a molecule which has structural homology to GLP-1. It was found in the saliva of a lizard called a Gila monster, and it was resistant to breakdown. So GLP-1 is broken down by DPP-4. And so this was manufactured and called exenatide. And this is a summary of the phase 3 clinical trials. So if you use exenatide injections in patients on metformin, sulfonylurea, or both, you're seeing at low dose and high dose reductions in HbA1c. And this is certainly telling us that the glucose lowering drug, which is great. Here was the big news, that you're seeing weight loss as well as glucose lowering. And that's the first time we really had a good weight reduction agent that also lowered glucose. So this is what we see for all of these agents, essentially. The longer acting ones really are becoming much more important, and what we now have is predominantly once weekly injections. So we've got here Bydureon, which with polymer technology, so the injection which sits subcutaneously and slowly dissolves. We have semaglutide here, which is Ozempic, and that's just been approved in our country and in use in some countries around the world. This is dulaglutide or Trulicity as a once weekly injection as well. And so these are becoming quite popular once weekly therapies. So what about the cardiovascular effects of these drugs? So the first one was the LEADER trial, and this really was also a game changer. So it showed this significant cardiovascular benefit. You can see cardiovascular death reduced significantly here compared with placebo. Similar result for semaglutide, the once a week injection here, where we've got the same signal here for cardiovascular outcomes. The Excel trial, this is exenatide once weekly, similar, although not quite statistically significant result. All-cause mortality was significantly reduced with this drug. Harmony with albiglutide, again, you've got a similar signal, a reduction in your cardiovascular outcomes. So you can see that all of these have the same signal. This is rewind with Trulicity or dulaglutide, and you've got the same results. So you can see once again that this is consistent. Mechanism not known. We can look at the components of MACE. So if you put all these trials together, you can see these reductions are consistent for MACE, for cardiovascular death, for fatal, non-fatal MI, and stroke. And so these are cardioprotective, again, as a class. Now, again, mechanism not at all clear. We really don't know, is this direct cardiovascular or cardiac effects? We know it has a small effect on blood pressure. We know it has an effect on weight, insulin production. But really, mechanism very much unknown, but these are cardioprotective drugs. So I think I'll finish there and just conclude by saying diabetes is associated with increased cardiovascular risk and mortality. We know that glucose lowering has an effect, but a modest effect on cardiovascular outcomes. It may be that early glucose lowering is much more important than in established disease. We know that the cardiovascular outcome trials have been tremendously important in giving us new insights. Most glucose lowering agents have established cardiovascular safety, but the two classes, SGLT2 inhibitors and GLP-1 agonists, appear to have cardiovascular benefits completely irrespective or over and above glucose lowering effects, and the mechanisms of these are yet to be established. So thank you very much for listening and your time today. I'm very happy to take any further questions.
Thank you very much, Prof. Cohen. Hello? 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 Thank you very much, Prof. Cohen. This is a very clear and impressive presentation. To any participants who still have questions to Prof. Cohen, please do so by writing down on the Q&A column in the screen. And I believe we have one question coming up. This is from Dr. Iwan Sulianto. He's an internist, and he has a question about the statin. What would you recommend at this moment? Is there any specific statin that you recommend, Prof?
Sorry, I didn't quite catch that question. Could you just repeat that for me?
So Dr. Iwan is asking about statin use. Yeah, do you have any specific recommendation for statin to use in this specific patient?
Or statins? I think, look, I think my impression is the statins are very good lipid lowering therapies. We generally associate the efficacy with the ability to lower LDL cholesterol, and there really isn't, in my mind, a significant difference. Of course, there are dosage differences, and some are more potent than others, but really your target needs to be, there's not sufficient difference between the statins to really advocate for one or the other. I think you know, as long as you're reaching your LDL targets, I think that's the main goal.
Okay. I don't see any other questions coming, but I would like to remind everybody, should they have any questions, just please do so. Just type on the our Q&A. Oh, we've got another one coming. So Dr. Irene Marina, she asks about, I would like to ask about how long someone must consume statin. They're all talking about statin.
Statins, yes. So these are long-term medications, and it depends a little bit on circumstances, of course, but if you have established cardiovascular disease, this is lifelong therapy, really, in the absence of any adverse effects. Again, I think you need to refer to local guidelines, but you should at least be able to maintain your LDL cholesterol in the appropriate range. So if you were to stop a statin, you would have to establish that you're able to maintain an LDL. So I think it's like most of these, you need to be a target or a target therapy, a target range. And if you stop it, you need to make sure you stay at target range. Otherwise, you're putting yourself at risk.
Right. So back to your presentation, Prof. I believe that there are some patients that they are doing their best to keep their blood glucose level under control, and we do understand that hypoglycemia will carry worse prognosis than the hyperglycemia. So, do you have any comments on how bad is the hypoglycemia due to the CV or other organs in comparison to hyperglycemia?
How bad is hypoglycemia?
Yeah.
So I think it's a really interesting story because we know there's an association with hypoglycemia and adverse cardiac events, but that doesn't mean there's cause and effect. And I think this is the big argument. Even though there's this association, one of the thoughts is that the association is not due to hypoglycemia, it's due to patients being fragile or frail. And that gives them increased risk rather than the hypoglycemia itself. So I think particularly with the insulin trial and with the trial, we're seeing, despite increased rates of hypoglycemia with insulin or with sulfonylurea, we didn't get a signal of increased cardiovascular outcomes. So if you do the trials, it's not actually showing a cause and effect. So what the thinking, and again, this is up for debate, and this is a lot of people debate this question, I think these trials suggest that the hypoglycemia itself does not cause cardiovascular outcomes, but has an association with it. So, my feeling is that you can be reasonably aggressive with your insulin and sulfonylureas and other agents and not fear adverse cardiovascular outcomes in these people due to hypoglycemia.
Okay. But comparing to those who have with hypoglycemia, hypo not hyper, do you have any certain concern about this? And do you know maybe any subset of patients that will at risk of having this hypoglycemia if using this SGLT2 inhibitors?
So, I think, as I say, I don't think hypoglycemia is a significant concern. I think the SGLT2 inhibitors don't actually cause hypoglycemia, so they're very safe. So if you have SGLT2s with metformin, for example, you really don't have an increased risk of hypoglycemia. So we're very happy using, and the same with the GLP-1 agonists as well. On their own, they don't cause hypoglycemia. It's really sulfonylurea and insulin that have that issue.
Okay. So we have another question, Prof, in our Q&A. Fifi will ask to you, do you have any experience using SGLT2 inhibitor in patients complicated with acute heart failure and diuretic resistance, considering that they usually present with acute kidney injury and eGFR lower than 30, which were excluded from the trials? And thank you.
These are agents that are being used for diabetes, but there is a recent study looking at heart failure patients, not all of who had diabetes, and that showed a significant heart failure benefit. And so there is now a growing indication for patients without diabetes to use SGLT2 inhibitors to prevent or treat heart failure. So I think that was the first part of the question. In terms of renal function, yes, you need eGFR greater than 45 in most countries and most indications now, but we are seeing benefits even down to eGFR of 30. And interestingly enough, not only are these agents cardioprotective, they are renoprotective. So we are seeing renal benefits of these agents also, despite the fact that you can't use them below a certain GFR level. So really, they are amazing wonder drugs in many respects.
Okay, I hope that would answer the questions. I think so. So another one, now we got a lot of questions, Prof. Nice. So how about, Dr. Pinkan would ask, how about the target with patients with hepatitis B and hypertriglyceride with hepatomegaly and fatty liver, the same target to younger or elderly patients?
So the target, I think he's asking, or she's asking about target of glucose. Was that correct?
Yeah.
So
glucose level control.
You know, I think that's an interesting question. So we don't have many studies specifically looking at that. Certainly, fatty liver is very common, and we recognise fatty liver is very common in people with obesity and diabetes, and we would target them very, very similarly. In fact, important to get weight loss in that group because that improves fatty liver. We know that hepatitis is associated with liver effects that increase insulin resistance. So you'd want to probably use agents that are, improving insulin resistance. And again, SGLT2 inhibitors, GLP-1 agonists are good. Metformin in that sort of line, whereas per se or sulfonylureas may not be such ideal choices given patients with liver disease.
Okay. So, okay, maybe we're gonna move to another question. So we got lots coming in. From Johannes Purwoto, Dr. Johannes would like to ask you, when would be the appropriate time to order examination of full lipoprotein profile or measurement when you do start to concern on the certain level of triglycerides in diabetes?
Yeah, so I think our standard practice in Australia would be to measure total cholesterol, HDL, LDL, triglycerides. That is a usual practice, and I think unless you've got an extreme level of hyperlipidemia, you're wondering about an unusual genetic condition or familial condition, I think that would be standard practice really to just order those tests. With triglyceride levels, the evidence is that triglycerides greater than 2 millimoles. I'm not sure if you're in millimoles or milligrams over there, but we would. The guidelines are that you would be treating a triglyceride level of greater than 2, which is associated with increased cardiovascular risk.
Okay. So it will go regarding to the local guidelines. Is that what you're saying, Prof?
Yes, I think that's very true in terms of lipids, and they do vary.
Okay, thank you. So is there any, Dr. Adit would ask you about, is there any questions, complication if you use GLP-1 agonist in underweight patients associated with loss issues?
So that's a good question. I think we know they're weight-losing agents, and so that is something that crosses our mind. In Australia, we don't have many underweight patients, I don't think, but it can happen. You can certainly have leaner patients with type 2, and I think in that group, you would be worried if they're very lean because the likelihood is you'll lose 3 or 4 kilograms of weight. So there's nothing specific studying that, I have to say. When you look at the trials and look at the different BMIs, the cardiovascular benefits were the same whether you were in the obese or non-obese range. So I think the benefits will still be there. But are we worried about making a thin patient thinner? I think that would be a slight concern to me. Well, it certainly wouldn't want my patients with a BMI of 23 losing, or 21 losing more weight. So I think we'd be a bit cautious about that.
So is there any cutoff point that you have to be more cautious in using these agents in underweight patients? Is there any BMI level cutoff?
Not as yet. I think that certainly if we had an underweight patient, so if we're looking at BMI less than 20, I would be concerned. Again, not many of those patients have been studied. Not many of those patients are in Australia, I don't think. But we would have concerns. But I think if your BMI is above 20, I think the benefits from these agents are still very powerful, particularly if you're in a high-risk cardiovascular group. So I don't think, you know, certainly because of these amazing cardiovascular benefits and even renal benefits, I think we wouldn't mind a few kilograms of weight loss, but we certainly don't want to make people underweight.
Okay. So we got another question. He said, thank you for a very clear presentation from Neil David Cohen, and I want to know about your comment about the risk of myopathy in using DPP-4 with statin. Do we have to decrease the dosage of statin?
No, I don't believe so. So there's no risk that I'm aware of with those two agents. I know there's been concerns about myopathy with statins, and I know there's been concern about arthralgia with DPP-4 and arthritis with DPP-4 inhibitors. I'm not aware of a link between the two at all. Certainly, I think the DPP-4 inhibitors are amongst the lowest side effect medication that I've ever seen, and I don't think there's any clear signal about myopathy or myalgia there. I know it's been reported in some of the literature, and I'm certainly stopping a statin is something that we're very much against in our country. You know, we know how beneficial they are, we know how important they are, we know how they're not fully utilised in the way they should be. So unless there's severe side effects, we wouldn't be recommending stopping a statin, particularly in your high-risk cardiovascular patients.
Okay. So I would like to go back to your topic about the cardiac effects of diabetic therapeutics. Would you suggest this agent as the first-line therapy for patients with diabetes and cardiovascular disease? Would you do it as the first line?
Yeah. So I think now the international guidelines essentially still recommend metformin first line. This issue of metformin, whether it's cardioprotective, and it's certainly less expensive. But the second line therapy for high risk patients now, if you look at the international guidelines, is that you consider SGLT2 or GLP-1 for patients who are high risk or have established cardiovascular disease or have renal disease. And if that's not the case, you could certainly look at other agents. But certainly that high risk group, I think now the thinking really is that these are second line therapies.
Okay, thank you. We don't have any more questions. I would encourage the participants, if you want to ask more questions, we still have time with our distinguished speaker. Do you have anything to add to your talk, Prof? This is very interesting.
Well, I think I think the other thing is that heart failure has become suddenly much more interesting, and we know the morbidity, mortality associated with heart failure, particularly in diabetes, and again, the SGLT2s in particular seem to have this really, really strong benefit on heart failure, and again, mechanism not entirely clear. So I think we're going to see more and more the use of these to prevent heart failure and even to manage heart failure. And many of my cardiology colleagues are jumping on board and prescribing these agents in that setting. So I think we shouldn't forget heart failure. We shouldn't forget subclinical heart failure, which is probably present in nearly 50% of our patients with diabetes. You know, the heart failure with preserved ejection fraction, etc. And so we should be very much on the lookout for patients who have subclinical heart failure.
Okay. No more questions. So, yeah, so this is a very interesting agent. So the first thing that you won't get hypoglycemia if you're using this agent, right, bro? And you won't get concerned about low body weight in starting this agent unless he is lower than 20 on BMI, right? And it could be an add-on therapy after you do metformin on diabetes patient with cardiovascular. So yeah, I think I got this one more question coming in, but I got a question to my personal phone. So are there studies among the patient in oral hypoglycemic and concomitant statins? She's asking about the study.
With hypoglycemics and statins, did you say?
Yeah, are there studies among the patients in oral hypoglycemic agents and concomitant statins?
Yeah, well, I think all of those studies that I showed you have patients, so the DPP and the complicated outcome studies have patients who are on oral agents, and most of them are on statins. So we have a large body of clinical trials looking at glucose-lowering agents in patients who are treated with cardiovascular drugs, including statins and ACEs and ARBs. So most of these studies are done in high-risk cardiac patients, including the heart failure study, which was done in patients who had heart failure, and not all of them had diabetes. So we've got a nice feeling for the high-risk cardiac patients, even without diabetes. And most of them, again, were on statins and aspirin and ACEs and ARBs. So, you know, I think there's no question of the benefit over and above glucose lowering, over and above lipid lowering, over and above blood pressure lowering. These are effects that are specific to GLP-1 agonists and SGLT2 inhibitors, which keep our patients alive for longer for reasons that we're not absolutely sure about.
Okay. Another question, Prof. Do you have experience using SGLT2 inhibitor on diabetic patients with urinary tract infection? Should we stop the agent?
So the major concern with SGLT2 inhibitors is genital infection, and mainly in women, but we're seeing a little bit in men as well. Urinary tract infection, there is perhaps, if anything, a small signal of increased risk of urinary tract infection. So with both of these, they're not necessarily indications to stop the medication, and you would treat the urine infection or the genital infection and the therapy. But if it's recurrent, I think you would then stop. So if you're getting a recurrent thrush or a recurrent urinary tract infection, then I would stop it. But again, you have to take this in the context of the benefit the patient is getting compared with the adverse effects. So I think an occasional bout of thrush or urinary infection is probably a small price to pay for the sort of cardiac and renal benefits you're getting. But certainly if you've got some of the recurrent thrush, recurrent UTI, you'd have to consider stopping. And this happens clinically. We do stop patients who have these adverse effects sometimes.
Oh, is there any other condition when we start to concern about stopping this agent, a part of this urinary tract infection?
Well, they're very safe. I think people were worried about dehydration in particular, but again, this is rare. The only slight concern which people need to be aware of is the very small risk of ketoacidosis. So ketoacidosis occurs in type 1 diabetes, but it rarely can occur in type 2 diabetes. And we're seeing a few cases now, unfortunately, for patients who have an intercurrent infection of some sort and they get sick and they're on an SGLT2 inhibitor, they start vomiting, and this can promote DKA. And so if that happens, they must come off the medication immediately. We now mandate that if they're having surgery of any sort, elective surgery, they have to come off the medication 3 days prior to surgery for this risk. So it's a little bit like metformin and dehydration. You have to stop these agents. These are small risks, but certainly everyone needs to be aware of the DKA and be aware of it and measure ketones if their patients are unwell on these agents.
So another question, Prof. How far, Dr. Harayutomo asked you, how far could we use combination between statin and fibrates for patients who suffered hypertriglyceridemia and hypercholesterolemia, especially with high VLDL with cardiomyopathy?
So the combination. Well, I think the combination with fenofibrate has been shown to be safe, and so the fenofibrate statin combination has been looked at, and I don't think there's any real concern. I think gemfibrozil was probably of more concern. There was a signal with that, But we do use this combination very regularly, and I think the risks of particularly myopathy don't seem to be there, at least in the